Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Steve Furr, president of the American Academy of Family Physicians, about From Heartland to Healthcare, the evolving specialty of family medicine. Let's get started. Dr. Dan, it is good to see you after quite some time.
Yeah, it's good to see you again, Faisel.
Dr. Furr, thank you so much for coming on today.
I'm glad to be here. I just wish I had as nice a tie as Dr. McCarter there. That's pretty impressive. We probably need to focus in on that a little bit more.
I started wearing bow ties doing a hand washing campaign because I felt like the only piece of clothing people didn't launder were ties. And so I started wearing bow ties then. And then after about a year, I put a long tie on and it felt like I had a cinder block tied around my neck. So ever since then, I've worn nothing but bow ties.
That's really impressive. And that goes with anything.
Well, Dr. Furr, I have a quick, we love to start off every conversation with just a question. And now you've been practicing for well over 30 years, almost 40 years. What has motivated you to become such a staunch advocate for improving our primary care system?
Well, I think the need as far as taking care of patients and the relationships with patients. I mean, there's a lot we can do in the exam room, but we also realize there's so many things that are going on both at the state and national level, where there's people coming into our exam room trying to tell us what we can and can't do with our patients, and also managing our medicines and trying to take care of patients. It's never been a better time to be a primary care physician. We can do more for our patients than we've ever done before. If we can get through all the administrative hassle, we can really do a great job of treating and taking care of our patients.
Especially as family doctors.
Yeah, we definitely have the biggest burden because we do so much. Because if you look at quality measures, we hit all the quality measures. If you're a specialist or another specialist or subspecialist, you might have 2 or 3 quality measures. We've had multiple ones, and of course, multiple medications along with that. So you're right. We take the brunt of the prior authorization. And I think there is, you've probably seen this too, there's some bias in the prior authorization. The cardiologist never has a trouble getting a stress test approved, or the orthopedist and the neurosurgeon never has trouble getting MRI approved. But we have to go through all this rigmarole to get those tests done. But at the same time, if they would let us get the test done, a lot of times we would not need that referral to the cardiologist or the neurosurgeon. We could cut that expense out.
That reminds me so much, especially in training, just the ability to curbside. Me and Dr. Dan, we talk often about, I remember just being able to curbside. We go in the physician's lounge and be able to just talk with one another. Hey, I'm thinking about doing this. Great. You handle it fast. You take care of it. I don't want to see that. If you can take care of it, I don't need to see that. I got plenty of other stuff to be dealing with.
Well, and I think that's the thing. I mean, there's not just a shortage of primary care physicians. There's a shortage of all specialists. It's 3 to 6 months to get in a rheumatologist, 5 to 6 months to get into a neurologist. And part of that, they're overwhelmed with patients they really don't need to see. They're patients that you and I can take care of if we're given the ability to do that. So that would take, with more of us, then it takes care of a lot of the shortage of the subspecialists, because we can handle a lot of those problems.
I noticed a quote at the FMX. I think they showed a video. And as I recall, you quoted there, your story is always being written. And then you went on to say, I like where I am today. But what story are you hoping that we in family medicine can write for family medicine and primary care in the remaining years of this decade?
One of the things that struck me the other day, I was talking with a reporter about some issue, and I kept referring to the specialty of family medicine. And when she got to the end, she came back to that and says, can you tell me about that? I never thought of family medicine as a specialty. So then we went into the details of that. So I think getting people first off to understand that we're the specialties above all specialties, okay? And that because of that, we're the only way to control healthcare costs. We're the only way to really improve patients' health and population health along with that. So if we really want to get America on the right track, control healthcare costs, and give people better health, it's all got to flow through us. And I think part of that is getting more primary care spend. And I think the message is finally getting out. I think Congress is hearing the message. Getting them to do what needs to be done is a whole different ballgame. But I think they do understand the message, and it is getting through.
You were talking about the specialty of family medicine, and Faisel and I were talking with Paul Grundy. At one point, he's considered the godfather of the patient-centered medical home, and he was describing that the family doctors, primary care doctors, are really the only specialists. Everybody else is a partialist. They specialize in part of the body or part or one organ system.
But they don't even specialize in one organ system. You go to an eye doctor, and they got a retina specialist, so it's not even one organ system. It's part of an organ system now.
I'd like to know about your experiences at the Family Medical Clinic in Jackson, how that experience there helped you shape your vision for how we can enhance healthcare delivery, especially in rural America.
So just give you an idea, when we first started a few decades ago, as you finally mentioned, when we first started, we had 2 doctors, family physicians, who came to town, and they had never had a board certified family physician here. They'd had some general practitioners, but never had a board certified family physician here. So we changed the mindset of the patients of what they were expecting to be their primary care doctor. So we came in, we met a need. And of course, in a rural area, the hospital doesn't survive if we're not doing well. And we're both interchanged together. So as these hospitals close in these rural areas, the physicians are also going to leave those areas too. So not only do you have OB deserts, then you have hospital deserts, but then you have total healthcare deserts because nobody's going to be there. Okay. What happens when you do have family physicians in a community, one, they support the hospital, but also on top of that, we're able to bring specialists in who would never come here because we've got a population density at our clinic. So we have a cardiologist that comes in once a week. We have a dermatologist that comes in every other month. We have a GI guy that comes in once a month. We used to have an orthopedist once a month. So our presence in the community allows us to bring other things in that would never be there otherwise. And of course, if we weren't here, you also wouldn't have your nursing care and that level of care too. So what it does in a rural community, when you lose your hospital, then you lose all your medical professionals. Pretty well all of them go, and everybody suffers. And in fact, there was just an article today talked about the fact that when people do go for surgery now in areas where there's less care in the primary care areas, they're usually sicker, more difficult surgeries because they weren't diagnosed earlier or were not referred as soon as they should have been. And again, you miss that preventive care that you would have gotten otherwise. You save that leg when it was a cellulitis that winds up becoming an amputation.
Does it frustrate you that now people have such access to information? And you would expect that with such access to information to be making better decisions, the public. But it seems like there's been a rise of misinformation.
I think everybody, the biggest psychological thing most people deal with is denial. So I think all patients tend to deal with denial to some extent and say it's really not that bad. And particularly in a rural area, we got a lot of really stoic, tough people who just kind of put it off. And particularly if healthcare is not easy and not available, then it's easier to put it off because it's not available. If they can see me in the same day, or they got to make an appointment, 80 miles away for 3 months away, then they're much less likely to go for their care. So I think we all deal with denial to a good extent, but then when care is not really available, I think that denial kind of takes over and they just don't get any care at all.
Yeah, and when we're talking about denial, that reminds me, years ago when I was in a rural practice, it was a Sunday afternoon, and I had a patient who also did some roofing work on my house occasionally. Anyway, he drove up to my house on Sunday afternoon, and his whole arm was swollen, and I was like, what's going on? He said, I just got bitten by a copperhead. And I'm like, well, why are you in my driveway? And he said, well, I wanted to come ask you what I should do about it. And I'm like, well, what we need to do is we need to get you to the hospital. So we made arrangements to do that. But I mean, he knew he needed to go to the hospital, but he wanted somebody that he trusted to actually tell him that he needed to go as well.
Oh, I don't know if you remember, I hate snake bites because you remember what it's like, because that antivenom you got to take there and carefully mix it and go back and forth like this. You can't just shake it up. You got to very carefully mix, and you're sitting there with 10 and 12 vials of antivenom trying to get it ready to go. So,
yeah, Dr. Furr, you were mentioning earlier about all these positive changes that are happening. People realize the value of high quality primary care. But so much of it involves us too, as family doctors, to become more effective leaders in this whole process of healthcare reform. But for many of us, most of us in family medicine are still working in that fee-for-service model with very, very tiny margins. I mean, we're talking with doctors with 2% margin, 2.5% margin. And so they're so busy in the day-to-day practice of being a family doctor. What are some of the strategies that some of these busy doctors, like they need to actions that they need to take in order to help empower us in the reform process?
Yeah, you're correct. The margins are small, and they're getting smaller with the Medicare cut, 3.4%. Now we've maybe cut that half of what that is, but there's most of your margin right there. And if you like most of us, we take home what's left over when we pay everything else. So usually that's our pay that gets cut there. So, but I think that's why we got to keep advocating. That's why we push so hard for the G2211 code. That's not moving value-based care, but still, it does for family physicians. We're the only one that can make up part of the Medicare loss by having that code available. None of the other specialists can make that up. So still pushing for those. There's now a social determinants of health code that we can code twice a year. But those are what we're moving to. But we've still got to realize that we've got to reward us for what we do. And that is moving more to a value-based model. But it's not going to happen overnight. It's going to take time and years to do that. But we've got to do things like we're doing with the G2211, make things that help support practices and get them there. But I tell you, if you're doing the extra things that you can build, if you got a strong chronic care management billing, even when I'm not in the office, we're billing $5,000 or $6,000 a month per doctor, chronic care management. Then if you're doing a G2211 code, you're doing transitions to care, there's remote patient monitoring. There's a lot of things that you can do that really takes care of the patient, provides better care, and also helps get your income up as a family physician.
Yeah, there's so many changes with these technologies even the technologies that you've mentioned, but I don't know what that would do to help also shift the expectations from the patient side, because sometimes some of these we'll be at a conference and there'll be somebody who'll come up to us, they'll see us, me and Dr. Dan out there, and they'll say, "Hey, I've got this neat gadget. And, this is going to be amazing for your diabetics. All you got to do is just sit over here and watch how this thing works." And they're selling us this whole thing. And no kidding, it didn't work. We were just within the last year, very nice people. And then they'll have these technologies and then it'll set an expectation, because we see these things. We've been around, somebody will come up with some fancy gizmo or gadget. Most of the time, it's not really something that is needed. People, like you said, they need the problems prevented. If it's something small, we can nip it in the bud. But
yeah, I agree with you. I have a love-hate relationship with technology. Technology always overhypes and overpromises what it can do, and a lot of times, sometimes it will deliver, but then it's usually 5 or 10 years. So now everybody's hyped with AI, and there's some things that are going to come out of AI, but there's also going to be some bad things that come out of it. But it'll be a while before it gets us there. So you're right. You got to take every bit of technology with a grain of salt. But even having there are with a patient that's congestive heart failure, you can get a scale that automatically delivers that to your EHR. You can record their glucoses now and get those into your EHR. So patients who have trouble getting in and out, there are some, but that's not really high tech. That's kind of basic tech stuff. Some of the high tech you're talking about, you're right, often doesn't work.
I understand that you have some information to share with us about how the match went. I mean, we're recording this on Monday, March 18th, and match day was just this past Friday. So how did match go for family medicine?
Yeah, we're real pleased that our numbers have continued to go up. We've matched more family medicine residents than we've ever matched before. There were still some open slots, and we believe most of those have already been filled through the supplemental SOAP that should have already happened. So most of those should have been filled. So those numbers have filled. However, our match rate at the beginning is still not what we'd like it to be. It's only at 88%. We would like to get that well above 90%. So we're glad and we're excited, but we're not stopping. One of the reasons we're matching more is there's more family medicine residencies out there, and we actually need more family medicine residencies, and particularly some of the teaching health centers where they're training them actually in communities and actually in underserved areas where they're more likely to stay. So the match numbers are good, but for us, they're still not good enough. So I want to be positive. But I want to let you know we've still got work to do. There is a trend where we're kind of level with our U.S. medical graduates and interest in family medicine. So, and when you look at it, there's a lot of variability from school to school. Uh, when I look at my medical school that I graduated from, what's interested, family medicine was up this year. Internal medicine and peds were way down. So when you look at trying to take care, when you talk about primary care, it's going to be us. It's going to be family medicine because so many of the internists are going to subspecialize. Many of the pediatricians are going to subspecialize. So it's going to be up to us to fill those gaps. So that's why our numbers need to be even better going forward. So good news, but I'm not satisfied.
And so for the people who just matched in family medicine, they may have some elective time coming up here before the end of the year. I know we're getting close to the end of the year. And I remember back when I was a resident, I was talking to Lewis Barnett, the chair of family medicine at UVA, and asking him what I should be thinking about in the spring of the last year as a rotation. And he suggested going back into anatomy and doing the autopsy service to, it'd be the last chance you'll really get to do dissections again. And so that would be a great thing to learn. I'm not sure that everybody needs to go back into the autopsy suite now, but what do you think would be important for somebody finishing medical school to learn before they start down this very heroic quest they're on?
Well, for me, one of my favorite ones I did as a fourth year medical student was emergency room rotation. Because, when you think when you're in a medical system, you're very rarely are you the first person to see the patient. Somebody has almost always seen them or evaluated them before you. So in the emergency room, you do get that firsthand approach. Or the same thing by rotating through the family medicine clinic there in your medical school, where you're actually the first person to see it. Because as a medical student, somebody's usually already worked them up. They've been admitted from the ER. You already got a diagnosis, and you're trying to. But so to really get your thought process going, you really want to get in situations where you're the first person to see them and work them up, because that's what you're going to start doing right away when you're an intern.
They need to have the continuity. They got to see it and follow through with that. Dr. Dan has had over the years, these ideas around making that the standard, where the students can go through and they can follow a family or follow so that they can see how things progress. So they're not just one touch and then somebody else comes and touches. I'm excited that there's a lot of good movement there to start measuring continuity.
I think that's a good point, because you think of how we learn. You mentioned earlier about going to these meetings, and most family physicians, we go to CME, but a lot of our learning is in the hall, talking with the other doctors and say, what are you doing now? What's working for you? But we're probably the only specialist that really learns for our patients over and over again, because we do have that continuity. We learn what drugs work, what drugs don't work, how people respond to medications. You think if all you do is ER, you see them once, and you think you gave them a good treatment, they all got better. And you don't know that unless you get a lawsuit and you find out they all didn't get better. But our sins always come back to us. We know about them, and if somebody didn't get better, they're not improving. We know that. And, one of the things I learned after practicing for a little bit, patients kind of think when they see you for that one visit, you've given it everything you've got. And if they don't get better, they need to go see somebody else, because you've done everything you can do. So I have this thing with every patient I see pretty well. I always say, listen, if you don't get better, come back, call me. There's other things we can do. You don't need to go somewhere else. I've got other things up my sleeve if this doesn't work.
Well, and that does. And the other thing that you can do is again, this is a trick out of Dr. Barnett's playbook, is you can tell the patient, I'll be thinking about you until the next time. And then the visit doesn't end, right? The relationship is still there. And they think, oh boy, Dr. Furr must really care about me, because he's going to be thinking about me till I come back in a month or 2 months or 3 months or whatever the time might be.
Yes, it's little things like that really make a difference to a patient. Like I have a guy who had to be hospitalized with COVID. He's in a tertiary care hospital. So my nurse called to check on him, and see how he was doing when he was going to get out. And he was just overwhelmed that we would take the time to do that. And it's simple things like that to take such little time, or just, when you have one of your patients die, going to the funeral or going to the funeral home for the wake, it just makes such an impression on them that you really care enough to do something like that.
But that's how you preserve the relationship.
And then you learn all kind of things in that when you go to the funeral home and you suddenly, because I didn't know that was his sister, and I didn't realize that I was treating his brother-in-law over here. You just learn all kind of things that we as family physicians often take for granted that other specialists never understand.
We can strengthen the bond in these. I mean, it's not high tech. I mean, even the things that you mentioned, the technologies that can help strengthen that bond between doctors and the patients, it's not high tech. I think that, I mean, if the technology is something that, like my 2-year-old now, actually, Dr. Dan, you're not going to believe this, Elias turned 2 today. My youngest just turned 2 today, so he's our miracle baby. But I see even him as a 2-year-old just scrolling through the phone. I mean, being able to use the phone, and it's incredible. It's incredible. Like you said, it's not high tech anymore. A lot of the things that we think, to be able to just FaceTime a patient, see what's going on and what they have in their cupboard, it's not high tech. So we can use a lot of basic technology to help strengthen the bond, and we should be using the technology to reduce some of the administrative burden.
Yeah, I think you bring up a good point. It is all about the touch. I mean, I'm seeing more and more where the patient comes back to me, they've seen another specialist, and they said he or she never laid a hand on me. They never touched me. And of course, I get the note back with this detailed, elaborate physical exam. And at first, I thought the patient didn't understand, but then my wife took her mother, had to see a nephrologist, and she said he never touched her. He really didn't. And had a great note and a great physical exam. So a patient never leaves my office. I don't put my hand on them in some way, whether it's touch them on the shoulder, listen to their heart, so that they know that and I've also got to get up close to them. I can't just stand across the room if I'm doing that. I've got to get up close to them.
My first year in practice, there was a lady came in one day to dispute the bill. And I'd remembered the visit. She had, I think her son was going through a divorce, or somebody in the family died. I don't remember the details. And I spent about an hour talking to her. I mean, I was just starting to practice, so I had plenty of time. And I billed her for a regular office visit, and she came back and she said, well, I didn't have a visit with Dr. McCarter. And the question, when I went out and I said, I remember spending an hour, but you didn't examine me. So after that, I got in the habit. I always take the stethoscope out. Doesn't matter what somebody's coming in for. I listen to their heart. At least that I know that I've touched them every time they come in. And so that nobody will ever leave saying that I haven't touched them when they were in the room after that.
The other thing too is you'll see a patient and you do an exam and that kind of stuff, and you get through and you're getting through, and they'll say, I'm going to schedule a appointment. I'm going to come in here for a full physical exam. I'm like, a full physical. For them, it's, they got trained that you need to have an EKG and you got to have all these other things. Even though you examine them, they don't think they got a full physical.
So you mentioned what students should be looking to do that were interested in going into family medicine. Now, fast forward, 3 years, and they're a senior resident and they've got some elective time. If somebody wanted to do what you're doing, especially on the advocacy side, what would you suggest what's available for residents to spend time doing before they finish residency to get ready to do that, to be ready to go in practice or ready to do advocacy?
I think one thing, because we're seeing so many vertically integrated systems and most of them spend all their time kind of within a hospital system, try and get out and see what other type of practices out there. See if you can get in a practice that's run by physicians. Maybe you want to try and get in with a DPC, a direct primary care practice, to see how they run. Maybe that's what you would like to do. But I think so many residents come out, it's easy just to do what they've always seen because they haven't had that experience in other settings. So I would try and see as many different settings as you can, what a small practice is like, a larger physician-run practice, like say DPC or something like that, because for some of them, a DPC might be exactly what they're looking for right out of the bag. But if they don't have any experience with that, they're scared to go out and do it on their own. So yeah, that third year of elective is a great time to get those kind of experiences and see things you wouldn't see otherwise.
Dr. Furr, so you've got a background in both, obviously we're hearing both sides, the clinical practice and then also in academia. How do you balance these roles enough to keep driving that positive change in primary care?
You read a lot to try and keep up with what's going on in the world. And you feed off your other physicians too. I mean, you learn from the other doctors. And then I was fortunate within our state when I served when what we really do as family physicians in our state, we feel like when you get on the family physician board, that's the beginning of your leadership, not the end. So we expect you to move on up. So we have multiple family physicians on our state medical board, also on our state board of health, also on our public health board. Because I've said it over and over again, I think family physicians are the best medical leaders. We're not the only leaders, but I think we're the best. We're the only one that really sees the total picture of healthcare, both from the physician perspective and the patient perspective. So I think any board that's medically related that doesn't have some family physicians on it is going to be missing a great opportunity to really lead forward where we need to be in a healthcare system.
What would you say? There's so many issues right now, and you're obviously leading the AAFP. What would you consider to be the number one, number two most pressing challenges facing family medicine right now, and then how can an organization like the AAFP help address those issues?
Well, our members tell us far and away, as you've already mentioned, administrative burden is far and away the biggest issue.
That's a big one. Yeah.
It's as big as it can be. And closely tied with that is we've got to get reimbursement up. A lot of the difficulties we're dealing with, you can get reimbursement up, both recruitment, retention, all those things are helped by that. And we are getting some, it won't happen until 2026, but we already have some improvements on Medicare Advantage as far as the prior authorization there. But we're trying to get some others through. There's a timely care for seniors that helps with some of the prior authorization bills. So actually, when I spoke before the Committee on Commerce and Energy, the doctors on that committee and the others, they understand, and because they're not hearing about just prior authorizations for us, they're hearing it from the patients. Their constituents are telling them. So it's on their radar. So we feel like we're moving that needle. So both at the federal level and the state level, we're not having to spend a lot of time explaining what the issue is. They know that. We just got to get the things passed through that gets rid of some of those things.
Part of it also is with being able to collaborate too, because everybody's being impacted by this. They're having, the patients aren't feeling that holistic care. I mean, they're feeling it. If it was ever, I don't know. I don't want to say it. I don't know if things could get even more fragmented than they already are.
Yeah, but you're right. It affects all specialties. We carry more of the burden because of the volume of work that we do. And the type of patients that we see, but it affects everybody. So everybody's in the same boat together. There's nowhere you're going to go that you're not going to escape.
Yeah, thank you so much for taking the time. This is fabulous. This has been a great conversation. In closing, what would be your message to our fellow family doctors? There's less than 100,000 of us in the country, about the transformative power of primary care with improving, because this is what everyone's talking about. How can we improve health outcomes, patient satisfaction, reducing costs? What would your message be to our fellow family doctors?
Yeah, we're still the drivers of the healthcare system, and we're the only ones that make a difference. The one thing you hear over and over again, we're the only specialty, if you put more of us in the area, that you improve care, you lower costs, and you increase health equity. And I think we've always got to realize that. We've got to drive that home. Putting more ophthalmologists out there, putting more dermatologists does none of those things. And we are the driver that makes that difference. And if America is going to get better health care, that's going to have to go through us. So there just needs to be more of us out there making that difference.
Thank you so much, Dr. Furr. That was very inspirational. Thank you very much.
And I'm going to see if I can find a sharper looking bow tie to wear next time.
We'll get you one.
There you go.
That'll be cool. Yeah.
What are your thoughts on From Heartland to Healthcare, the evolving specialty of family medicine? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.